Welcome back to the deep dive. We're here to really break down complex topics into the essentials you need.
That's the plan, making revision efficient and hopefully a bit clearer.
And today, our focus is squarely on hip dislocation. We're working from some revision notes, and the mission is simple. Give you a high-yield overview.
Exactly. All the key info definition, causes, risks, management, everything you need to know distilled down.
Perfect. So let's start at the beginning. What is a hip dislocation, fundamentally?
Yeah, so simply put, it's when the ball part of your thigh bone, that's the femoral head, gets forced out of the hip socket, the acetabulum,
Okay. Ball out of socket.
pretty much. And the notes really stress that it's usually caused by some kind of significant trauma. Think big accidents, major falls.
Right.
And what's super important and flagged in the notes is getting it diagnosed and managed quickly. It makes a huge difference to the outcome.
Okay, so speed is key. Is it just one way it happens, or are there different types?
Good question. No, there are different types based on which way the femoral head goes. The most common one by far, like 90% of the time, is posterior dislocation.
Posterior, 90%. Got it.
Yeah. And with that one, the leg typically looks shortened. It's pulled inwards, that's adducted, and rotated inwards, internally rotated.
Okay, short, pulled in, rotated in.
Exactly. There's actually a handy mnemonic the notes mention. P.I.SHAD. Posterior, internal rotation, shortened, adducted.
P.I.SHAD. Nice. That helps it stick. What about the other types?
Right, so less common, you've got anterior dislocations. Here the leg tends to be moved away from the body, abducted, and rotated outwards, externally rotated.
Opposite position then, mostly.
Yeah, and a key thing with anterior ones, usually no shortening of the leg. That's a big difference. And then even less common is a central dislocation.
Okay.
But the main takeaway for all traumatic types, anterior, posterior, central, is that usually takes a lot of force to make it happen.
Right. Significant force. We've mentioned trauma, like accidents and falls. Are there other causes we should know about?
Yeah, well, that high-energy trauma is the big one. The notes do list a few others. Sports injuries, definitely, especially in contact or high-impact sports.
Makes sense.
Sometimes it can actually be a complication after someone's had a hip replacement.
Oh, interesting.
And also conditions someone might be born with that affect hip stability, like congenital hip dysplasia, where the socket isn't formed quite right, isn't deep enough.
So the joint's just inherently less stable.
Exactly. That can predispose someone to dislocation.
Okay, so that leads into risk factors then. Who's more likely to end up with a dislocated hip?
Well, linking back to the causes, people involved in high-impact sports or activities are obviously at higher risk.
Right.
Also, anyone with a previous history of hip injuries or maybe hip surgery, that can sometimes affect stability. And then those underlying conditions we just touched on, congenital hip dysplasia is a big one mentioned in the notes, especially for recurrent dislocations. Also, things like general ligament laxity, where ligaments are just stretchier, can play a role. Acetabular dysplasia, that shallow socket, is specifically flagged as increasing risk.
Makes sense. So when it does happen, what's going on structurally inside the joint? The pathophysiology.
So fundamentally, you've lost that normal alignment. And that, of course, causes damage. You're looking at potential stretching or, tearing of the ligaments that hold the joint together. The joint capsule itself can be damaged. And importantly, blood vessels supplying the femoral head can get compressed or torn, and nearby nerves, like the sciatic nerve, can be stretched or injured too. So it's not just the bone placement, it's the whole surrounding structure that's affected.
Okay, quite a lot of potential damage there. So if someone presents with hip pain after, say, a fall, how do you differentiate a dislocation from other things? What are the differentials?
Yeah, crucial point. You've got to rule out other possibilities.
Yeah.
The notes highlight a few key ones. Obviously, hip fracture is a break in the bone itself rather than displacement.
Right, fracture versus dislocation.
Exactly. Could also be a hip contusion, just a really bad bruise, or less commonly, maybe a joint infection, though that usually comes with other signs like fever.
Okay.
And just other general traumatic injuries to the hip region need consideration too.
Got it. Need to keep those in mind. What about how common this is, the epidemiology?
It varies a bit. We tend to see it more in two main groups: younger people, often due to those high-impact activities or accidents, and older adults, where falls are a much bigger factor. As we said, posterior is the vast majority, about 90%.
So 90%.
Yep. An interesting point from the notes is that the overall incidence seems to have decreased over time.
Oh, really? Why is that?
It's thought to be largely down to better car safety, features airbags, seatbelts, crumple zones, reducing the impact forces in accidents.
That makes sense.
We also see it slightly more in young males, which might be linked to, risk-associated activity.
Okay.
But a sobering statistic mentioned is that long-term disability isn't uncommon. About half of people might have ongoing pain or reduced mobility afterwards.
Wow, half. That really highlights the seriousness. So what are the classic signs if you see someone what screams hip dislocation, the clinical presentation?
Usually it's pretty dramatic. Severe hip pain is almost universal. They won't be able to put any weight on that leg or move it much at all.
Okay, extreme pain, can't weight bear.
Yeah. And often you can actually see that the leg is in an abnormal position, a visible deformity. Range of motion is obviously very restricted.
And does the position tell you the type?
It's a massive clue. Remember, P.I.SHAD for posterior.
Posterior internal rotation, shortened, adducted.
Spot on. That's the classic picture for the most common type.
And for the anterior type, less common, but how does that look?
So anterior is different. Think A.E.E. Anterior, extended, externally rotated, abducted. So the leg is out to the side, rotated outwards.
A.E.E.
Got it. And the key thing, again, NO shortening, usually with anterior. That helps distinguish it.
Okay, so clinical picture is pretty strong. What investigations confirm it?
First step is usually an X-ray. That's your go-to. It'll confirm the dislocation, show you which type it is, and crucially check for any associated fractures, which are quite common.
Right, X-ray first. Anything else?
Sometimes, yeah. A CT scan might be used to get a better look at the bone detail, especially if they suspect complex fractures of the socket, the acetabulum.
Okay.
And an MRI could be useful down the line to assess damage to soft tissues, ligaments, cartilage, or to check for things like a vascular necrosis, which we'll get to.
Right. So diagnosis confirmed. What's the plan? How is it managed, particularly thinking about UK practice?
The absolute main aim is to get that femoral head back in the socket that's reduction.
Okay.
So initial steps are the usual ABCDE assessment to check for other life-threatening injuries, especially with major trauma. Then good pain relief analgesia is vital.
Makes sense. Sounds incredibly painful.
Oh, definitely. And then urgent referral for reduction. This is nearly always done under general anesthetics.
Why under anesthetic?
Need the muscles around the hip to be completely relaxed. Otherwise, trying to pull against muscle spasm is really difficult and risks causing more damage. And ideally, the notes stress this, reduction should happen within 4 hours of the injury.
4 hours? That sounds like a critical window.
It really is. We'll talk about why when we get to complication.
Okay. So how is the reduction actually done?
Usually, it's a closed reduction. That means no surgery is needed initially. The doctor uses specific manual techniques, basically pulling and rotating the leg in a controlled way, to manipulate the femoral head back into the socket.
Like a physical maneuver.
Yeah. Once it's back in, they'll confirm it with another X-ray, and then the hip is usually immobilized for a period, maybe in a splint or brace, to let the damaged tissue start healing.
And after immobilization?
Physical therapy is key. That's the long-term management, regaining strength, flexibility, and function. Surgery might come into play later if the closed reduction doesn't work, or if there are significant associated fractures or ligament tears that need fixing.
Okay, comprehensive approach. What about the overall outlook? The prognosis?
It's variable, honestly. Depends heavily on the type of dislocation, how severe it was, if there were other injuries like fractures, and crucially, how quickly that reduction was done.
Back to that time window again.
Exactly. If everything goes well, prompt treatment, good rehab, then good functional outcomes are definitely possible. People can get back to normal activities. But there are potential complications that can definitely affect the prognosis.
Right. Let's talk about those potential complications then. What are the main risks?
Okay, probably the most significant one to be aware of is a vascular necrosis, or AVN.
What's that?
That's where the blood supply to the femoral head gets disrupted by the injury. If the bone doesn't get enough blood, it can die.
That sounds serious.
It is. And the risk of AVN goes up significantly the longer the hip stays dislocated. That's why that 4-hour window for reduction is pushed so hard. Delay dramatically increases the chance of AVN.
Okay, AVN linked to delay. What else?
Nerve injury is another one. The sciatic nerve runs right behind the hip joint, so it's vulnerable, especially in posterior dislocations. The femoral nerve can be affected in anterior ones. Usually it's temporary stretching, but permanent damage can happen, though it's rarer.
Nerves too.
Fractures, as we mentioned. Fractures of the femoral head itself or the acetabulum often happen at the same time as the dislocation.
Right, associated injuries.
Yeah. Then there's post-traumatic arthritis.
Yeah.
Basically, damage to the joint surface cartilage during the dislocation can lead to arthritis developing later on, sometimes years down the line. This is more common in older patients and might eventually mean they need a hip replacement.
Arthritis later on.
Recurrent dislocation can also be an issue, especially if ligaments were badly damaged and don't heal properly, leaving the joint a bit unstable.
So it could pop out again.
Potentially, yeah.
Yeah.
And unfortunately, mortality is a risk, though usually it's not from the hip dislocation itself, but from other major injuries sustained in the same traumatic event, like serious head, chest, or pelvic injuries.
Right. Associated trauma again.
And lastly, don't forget venous complications. Being immobile after a major injury like this puts people at high risk of deep vein thrombosis, BVT, and pulmonary embolism, PE. And sometimes, very rarely, the femoral artery can be injured.
Wow, quite a list of potential problems. Really underlines the need for good, fast care.
Absolutely. Timely reduction and careful follow-up are crucial.
Okay, so just to quickly recap our deep dive on hip dislocation.
We've covered the definition femoral head out of acetabulum, the types posterior, P.I.SHAD, being most common, anterior, A.E.E., A.E.E. less so, causes mainly high-energy trauma, but also sports, post-surgery, congenital issues, risk factors like sports, previous injury, dysplasia, what happens inside the joint ligament, vessel, nerve damage, how to differentiate it, the epidemiology showing higher risk in young males and older adults, and that concerning long-term disability rate.
Yep. And the clinical signs: pain, immobility, deformity, those specific leg positions, investigations X-ray first, CT MRI if needed.
And the management ABCDE, analgesia, urgent reduction under anesthetic within that key 4-hour window, followed by immobilization and physio. And finally, those significant complications, AVN being a major one linked to delay, nerve injury, fractures, arthritis, recurrence, and VTE risk.
That's a fantastic summary. Really getting a handle on all those aspects is so important for revision and understanding. And if you are revising for your MSRA exams, definitely check out passmsra.com for loads of great resources.
Yeah, it's a really valuable tool. And also, don't forget freemsra.com, another excellent resource, completely free to help with your prep.
Great plugs. Okay, let's leave you with a final thought to mull over. Considering that risk of a vascular necrosis, that potentially devastating complication, what specific challenges do you think clinicians face in actually achieving that reduction within the crucial 4-hour window in a real-world emergency setting? Something to think about.